You've probably experienced this exact scenario before. You walk down the skincare aisle of your local pharmacy because you're desperately looking for a solution to like a sudden breakout.
Oh, and you are instantly paralyzed.
Yes, exactly. You're just staring at this massive wall of brightly colored bottles, and they're all promising these absolute miracles.
Right, but then you turn the box around and the back reads like like a high-level chemistry exam.
It really does. It's just multisyllabic acids, varying percentages, and all this aggressive marketing designed to convince you that unless you adopt like a 12-step morning routine, your skin will just never be acceptable.
Yeah, and it's incredibly overwhelming. I mean, it feels like wandering into a laboratory without a manual.
Which is a perfect way to put it. And honestly, the skincare industry kind of thrives on that exact feeling of overwhelm.
They do. But the thing is, when you bypass all that marketing noise and look directly at what dermatologists actually prescribe, the approach completely shifts. There's a really rigid, fascinating science to this.
And that is exactly our mission for this deep dive today. We are throwing away the glossy marketing brochures and we're handing you the actual scientific manual.
Right. We're looking at a comprehensive clinical overview that details the current medical approach to managing mild acne vulgaris.
So whether you're currently battling a breakout, or maybe you're trying to help a teenager navigate the whole nightmare of skin changes, or, you're just fiercely curious about how these chemicals physically alter your cells, consider this your ultimate cheat sheet.
But I think before we delve into the actual chemicals, we really need to establish exactly what the medical community means by mild acne, because it's not always what the average person thinks.
Right. It's not just a subjective feeling of like, oh, my skin looks bad today.
Exactly. In clinical terms, mild acne vulgaris is highly specific. It presents as scattered comedones, which that's just the scientific term for your standard blackheads and whiteheads.
Okay, so blackheads and whiteheads.
Yeah, or small inflammatory papules that are under 5 millimeters. But most importantly, to be classified as mild, there can be absolutely no scarring.
No deep inflammatory nodules, right?
Right. And the breakouts are generally scattered. They aren't covering the entire face in like a continuous sheet.
There is a really vital distinction to make here, though, that I noticed in the source material. The physical manifestation might be categorized as mild by a doctor who's just, checking boxes on a chart, but the psychological impact is never mild.
No, not at all. And the clinical overview is very explicit about this,
Yeah,
actually.
it really goes out of its way to validate the patient's reality.
It does. The medical community acknowledges that acne vulgaris, I mean, even in its mildest physical forms, it directly contributes to low self-esteem, depression, and severe anxiety.
The psychological toll is just profound.
It is. And
Yeah.
this is precisely why effective treatment is so critical. It's not just a matter of vanity, It's a matter of preserving a patient's mental health and their overall well-being.
So let's open up this manual and figure out how to actually treat it.
Yeah.
Because I think the logical assumption most of us make is, okay, a pimple is caused by bacteria, so I should immediately buy something that scorches the earth and kills the bacteria.
That's the instinct.
But the literature suggests we're actually starting at the wrong step there.
We are. Because before fighting the bacteria, we actually have to remodel the environment where that bacteria lives.
Which is such a wild concept.
It's the whole foundation of modern dermatology, really. You have to clear the microscopic traffic jams that are happening inside the pores.
Okay, and how do we do that?
Well, to do that, the undisputed MVPs of mild acne treatment are topical retinoids. We're talking about compounds like tretinoin, adapalene, tazarotene, and trifarotene.
And the clinical guidelines state these should be the initial management step for like almost every single patient, right?
Almost every single one, yes.
The mechanism behind these retinoids is honestly mind-blowing to me. Because I think the common assumption is that these creams act like, I don't know, an invisible scrub.
Like an exfoliant.
Yeah, we picture them just sitting on the surface of the skin, sort of melting away dead cells, but they're actually doing something much, much deeper. They're altering the skin at a genetic level.
They absolutely are. So topical retinoids are essentially derivatives of vitamin A. And when you rub them onto your face, they don't just sit there.
They dive in.
They do. They penetrate your skin cells, specifically the keratinocytes,
Right.
and they physically bind to 2 specific families of receptors inside the nucleus.
Okay, inside the nucleus.
Right. The retinoic acid receptors, or RRs, and the retinoid X receptors, the RXRs.
So the chemical is driving straight into the literal command center of the cell.
Precisely. And once that retinoid binds to the receptor, it alters DNA transcription.
Wow.
It literally changes the instructions the cell is receiving. It tells the specific target genes to normalize follicular keratinization.
Okay, let's translate that for a second. So follicular refers to the follicle or the pore, and keratinization is the process of skin cell shedding.
Yes, because in an acne-prone person, those dead skin cells, they don't shed normally. They clump together like a sticky paste.
Right, which we call follicular hyperkeratosis.
Exactly. So the retinoid changes the genetic instructions so the cells just stop clumping.
So they act like cellular traffic cops.
That is a perfect analogy, actually.
Yeah, they step into the intersection of your pore, blow a whistle, and just force the skin cells to keep moving in an orderly fashion instead of piling up and causing this massive collision.
Exactly. And by forcing the cells to keep moving, you prevent the microcomedo, which is the very first stage of a clogged pore, from ever forming in the first place.
You're dismantling the acne cycle before it even has a chance to begin.
You really are.
Now, the clinical data has some bizarrely specific details about these drugs, too. There was this one warning that stood out immediately to me.
Oh, the fish allergy.
Yes. A product called micronized tretinoin 0.05% gel comes with a strict caution for anyone with a fish allergy.
I know, it sounds like a misprint, but it is entirely real. That specific formulation utilizes soluble fish proteins to help deliver the medication into the skin.
That is wild. I mean, it's a prime example of why reading the actual medical literature gives you an edge.
Oh, for sure. The average person would never pick up a tube of acne gel and wonder if they need an EpiPen because it might contain fish.
Unbelievable. The literature also leans heavily on clinical trials to prove these aren't just, theoretical benefits. It highlights two major 12-week trials known as Perfect 1 and Perfect 2.
Right, so those trials were testing a newer retinoid called trifarotene.
And what makes that one so special?
Well, what makes trifarotene unique is that it selectively targets just the RRR gamma receptor, which makes it incredibly precise. But the reason Perfect 1 and 2 are so heavily cited is that they prove the drug works beautifully, not just for the face, but for truncal acne.
Which means the chest, the shoulders, and the back.
Exactly.
And anyone who has dealt with body acne knows it is notoriously stubborn. So having a targeted genetic treatment for that is a massive win. But we cannot gloss over the safety warnings here, particularly concerning pregnancy.
Right. The clinical consensus is absolute on this. Topical retinoids are strictly not recommended during pregnancy.
But there is an interesting nuance, right?
There is. A large systematic review and meta-analysis actually found no significant increase in major first trimester congenital abnormalities from inadvertent exposure.
Meaning, like, if you were using a retinoid cream and suddenly found out you were pregnant, the data suggests you probably haven't caused catastrophic harm.
Yes, which provides immense reassurance to panicked patients. However, the studies weren't powerful enough to declare the drugs unequivocally safe.
Because there are still documented case reports.
Exactly. There are documented case reports of fetal malformations in infants whose mothers used topical retinoids. So because that risk exists, no matter how small, dermatologists will pull you off retinoids the moment you start trying to conceive.
That makes total sense. Okay, so let's look at this from the perspective of someone standing in their bathroom. If these cellular traffic cops are the absolute holy grail of skincare, why is there such a high failure rate?
That's a big question.
Because so many people buy a retinoid, use it for like 6 days, and then throw the tube away because their face is just inflamed and peeling off.
Well, this is where human behavior really clashes with clinical design. The failure is almost always in the application.
Okay, how so?
Skin irritation, severe dryness, flaking. These are completely expected side effects, particularly during the first 4 weeks. But the clinical guidelines emphasize a strict start slow protocol.
You can't just slather a thick layer of tretinoin onto your face every night and expect glowing skin.
No, not at all. There are very specific rules. You use a pea-sized amount for the entire face.
Just a piece out.
Just a pea size. And you start by applying it only every 3rd night. Over several weeks, you slowly train your skin to tolerate it.
Wow.
Furthermore, moisture is the enemy of application here.
Wait, really? Why?
Applying a retinoid to damp skin drastically increases how deeply it absorbs, which just skyrockets the irritation. The clinical rule of thumb is to wash your face, dry it completely, and then force yourself to wait a full 20 minutes before applying the drug.
The 20-minute rule. See, that is the kind of detail left out of the glossy magazine ads.
Oh, absolutely.
So if we follow the rules, the retinoid traffic cops clear the pore. The environment is remodeled. Now we actually have to deal with the C. acnes bacteria that is colonizing the skin and causing that angry red inflammation.
Right. Enter the antimicrobial arsenal.
Yes, which is dominated by two forces, benzoyl peroxide, commonly called BP, and topical antibiotics like clindamycin.
Benzoyl peroxide is such a fascinating molecule because it attacks the problem from two directions. It's chemolytic, meaning it helps break down the clogged pore, and it's a potent antibacterial.
And the most crucial fact about BP is that throughout decades of use, the acne bacteria has never once been shown to develop a resistance to it.
Never. But the clinical literature completely demolishes a massive myth about benzoyl peroxide here.
Oh, the concentration myth.
Yes. If you look at the pharmacy shelf, you'll see 2.5%, 5%, and 10% formulas.
Right, and human nature dictates that higher numbers equal better, faster results. We just assume that if the 10% cream burns more, it means it's destroying the acne 4 times as fast.
It's a logical assumption, but it's entirely false.
Really?
The clinical trials explicitly demonstrate that a 2.5% concentration of benzoyl peroxide is just as effective at reducing inflammatory acne lesions as the 10% concentration.
That is wild. They do the exact same amount of work.
The exact same. The only difference is that the 10% concentration causes dramatically more skin irritation, peeling, and barrier damage.
So you are enduring significantly more pain for 0 additional benefit.
Basically, yes.
That alone will save the listener so much money and misery. Just buy the 2.5% and protect your skin barrier. But let's look at the other weapon you mentioned, topical antibiotics, like clindamycin. I would assume an antibiotic is the ultimate fix for a bacterial issue.
It's a powerful fix, but the medical literature issues a stern warning here. Using a topical antibiotic entirely by itself is considered terrible medical practice today.
Why is that?
If you apply clindamycin alone, you will rapidly promote the survival and replication of antibiotic-resistant strains of C. acnes.
Ah, you're basically putting the bacteria through a selective training camp, like sending them to the gym.
Exactly.
The weak ones die, but the strong ones learn how to survive the antibiotic, and then they just multiply.
Precisely. To prevent the creation of these super strains, topical antibiotics must always be used alongside benzoyl peroxide because the bacteria cannot adapt to BP. Combining the two drugs drastically decreases the development of resistance.
They protect each other's efficacy.
They do.
But this brings us to a massive hidden danger in the chemistry lab, the chemistry clash. You cannot just blindly mix these MVPs together on your face without understanding how they interact.
You really cannot. The most classic patient error is applying traditional tretinoin and benzoyl peroxide at the exact same time.
Right.
Benzoyl peroxide is an extremely potent oxidizing agent. And oxidation essentially means it strips electrons away from other molecules, breaking them down.
Right, so if you layer it over tretinoin,
The BP literally oxidizes and shreds the tretinoin molecule on contact.
you're destroying the traffic cop before it can even reach the cell nucleus.
Exactly. You're paying for a prescription and then immediately neutralizing it.
Wow, so the clinical safeguard is simple separation.
Yes, benzoyl peroxide is applied in the morning, and the tretinoin is applied in the evening.
Now, I know some newer, heavily engineered formulations encapsulate the tretinoid, or they use more stable retinoids like adipoline, which can withstand the BP.
Right, but separating them really remains the gold standard for protecting the chemicals.
There are also a couple of highly practical warnings regarding benzoyl peroxide in the source material. First, the FDA points out there's a rare but life-threatening risk of severe hypersensitivity reactions to both BP and salicylic acid.
Yes, which is why they recommend doing a 3-day patch test on a tiny area of skin before you cover your whole face in it.
And secondly, there is the laundry issue.
Oh, the infamous bleaching effect.
Yes.
Benzoyl peroxide will completely strip the dye out of your fabrics. If you apply it at night and go to sleep, or wipe your face on a bath towel, you will wake up to ruined, bleached pillowcases and shirts.
Every teenager has ruined at least one good towel this way.
Yeah.
I know I did.
Oh, definitely.
So we have the ingredients. We know to use 2.5% BP. We know to wait 20 minutes for retinoids. And we know to keep them separated. But what happens when a patient does everything right and their acne still just refuses to budge?
Well, when a first-line treatment fails, a skilled dermatologist doesn't immediately throw the drug away and write a different prescription. Yeah, because the active chemical is usually fine. The failure almost always lies in the delivery system, what the medical field calls the vehicle, or in human error.
Let's explore that vehicle concept because it proves that the texture of the medicine is literally just as important as the medicine itself.
Absolutely. The vehicle dictates the patient's willingness to use the product. If you have incredibly oily skin and the pharmacy gives you your medicine suspended in a heavy, greasy ointment,
You're going to hate it.
you're going to despise how it feels, and you simply will not apply it. So for oily skin, alcohol-based gels are superior because they offer an immediate, satisfying drying effect.
Right?
Conversely, if you have dry, easily irritated skin, those gels will sting. So you need the drug suspended in a moisturizing cream.
And what about the truncal acne we discussed earlier? Treating the back or a hairy chest with a thick cream sounds like a logistical nightmare.
It is a nightmare, which is exactly why foams and liquid washes were developed. A foam can spread rapidly over a hairy area like a beard or chest without matting the hair down.
Oh, that makes sense.
And a liquid wash can cover the entire back while you're just standing in the shower. If the vehicle is wrong, the treatment fails.
But let's assume the vehicle is perfect. The patient has the right gel. There's this fascinating detail from the source material regarding how doctors troubleshoot these failures using basic human psychology.
Oh, the adherence questions.
Yes, a doctor won't simply ask, "Are you applying your cream every night?"
Right, because human beings are wired to avoid disappointing authority figures. If a doctor asks a direct yes or no question about adherence, the patient will instinctively say yes to avoid judgment.
Even if that tube of cream has been lost in a bathroom drawer for a month.
Exactly. So to bypass this, the literature trains doctors to ask open-ended questions like, describe your typical morning routine for me.
It is such a clever diagnostic tool. It removes the accusation. Because having the perfect prescription medication is a lot like buying custom-fitted, highly expensive prescription glasses. If those glasses pinch the bridge of your nose and you leave them sitting on your nightstand, they cannot fix your vision.
The drug cannot alter your DNA from inside the plastic tube.
Exactly.
So lack of adherence is the #1 cause of failure. However, if a patient is genuinely applying the medication perfectly, the doctor must pivot and consider a misdiagnosis.
Because there are conditions that perfectly mimic acne vulgaris.
Right. Yes, but they require entirely different treatments. For example, an overgrowth of Demodex mites, which are microscopic mites that naturally live in human hair follicles that can cause severe acne-like bumps.
Ugh.
Similarly, a fungal overgrowth called pityrosporum folliculitis looks identical to acne, and neither of these will respond to benzoyl peroxide or retinoids.
And beyond misdiagnosis, the literature points to deeper internal mechanisms too.
Yes. The doctor has to look for signs of hyperandrogenism, which is an excess of male sex hormones. If a patient's hormones are severely unbalanced, those internal signals will constantly overdrive the oil glands.
Completely overpowering whatever topical creams you're applying on the outside.
Pres-
So if the issue isn't adherence and the diagnosis is correct, the manual offers some alternative workhorses. Salicylic acid is mentioned for patients who simply cannot tolerate retinoid irritation, but the compound that really stands out to me is azelaic acid.
Azelaic acid is an incredibly elegant, multitasking molecule. It's classified as a naturally occurring dicarboxylic acid.
Which means what exactly?
To demystify that term, it's an organic compound naturally found in things like wheat, rye, and barley. It works brilliantly because it is antimicrobial, it sweeps out the pores, and it drastically reduces inflammation.
But the real magic trick of azelaic acid is how it handles the aftermath of the pimple, right?
Exactly. It has a unique ability to inhibit an enzyme called tyrosinase. And tyrosinase is the key enzyme responsible for producing melanin, the pigment that gives our skin its color.
So by inhibiting that enzyme, what is the actual result on the face?
It directly shuts down post-inflammatory hyperpigmentation.
Oh, wow.
Yeah, when a pimple finally heals, it often leaves behind a dark, stubborn spot that can take months to fade. Azelaic acid prevents the overproduction of melanin in that specific spot.
So it treats the active breakout while simultaneously erasing the dark mark it leaves behind.
Exactly.
It is treating the past and the present at the exact same time. Now, what if we exhaust all these primary options? The patient is perfectly adherent, the vehicle is great, but the standard retinoid and BP combo simply isn't working. Where does the medical literature point us next?
It points us toward the newer, highly specialized second-line defenses, the clinical wildcards. A prime example is topical dapsone. It's available as a gel, and it is phenomenally effective at treating deep inflammatory acne.
But topical dapsone comes with a completely bizarre chemical reaction if you forget the separation rules we talked about earlier.
Oh, it's a very visual punishment for breaking the rules. If you apply topical dapsone and benzoyl peroxide to your face at the same time, a rapid chemical reaction takes place right on the surface of your skin.
And what happens?
It will instantly stain your skin and your facial hair a bright, vibrant yellow or orange.
The accidental Oompa Loompa effect.
Yes.
It's a hilarious visual, but honestly, it's a stern reminder that these are highly reactive chemicals. And the literature notes this orange staining can persist for up to 2 months.
Which is precisely why dermatologists are so adamant about separating your morning and evening routines. You must wash your face thoroughly before switching medications.
So what else is in the wild card category?
There is a newer treatment called minocycline 4% foam. We established earlier that you shouldn't use topical antibiotics alone, but this specific foam formulation was recently FDA approved to treat moderate to severe acne.
Okay, but what's the catch?
What's critical to note here are the side effects. In clinical trials, patients didn't just experience local skin redness. They reported systemic effects, primarily headaches, and elevated levels of creatinine phosphokinase in their blood.
Okay, we need to pause on that term. What is creatinine phosphokinase, and why should a listener care if it's elevated?
Creatinine phosphokinase is an enzyme found mostly in your muscles and your heart. When your muscles experience stress or damage, that enzyme leaks into your bloodstream.
Right.
So seeing elevated levels from a skin foam suggests the medication is absorbing deeply enough to cause systemic stress.
That is a crucial realization. A foam you just casually rub on your cheek can potentially cause a headache and muscle enzyme spikes. It really shatters the illusion that skincare just stays on the surface.
It does.
Which leads us perfectly to the final and arguably most fascinating wild card in the literature.
Why?
Clascoterone 1% cream, which was approved in 2020.
Clascoterone is a massive leap forward in dermatological science. It utilizes an entirely new mechanism of action. It's a topical androgen receptor inhibitor.
Wait, let me make sure I'm understanding this. Is this essentially a localized topical hormone blocker just for your face?
That is precisely what it is. We know that acne is heavily fueled by androgens, specifically a powerful hormone called dihydrotestosterone, or DHT. In acne-prone individuals, DHT binds to receptors inside the skin and commands the sebaceous glands to overproduce massive amounts of sebum, which is the oil that feeds the acne bacteria.
So what does clascoterone do when it hits the skin?
It physically competes with the DHT. It locks into those specific receptors in the skin, acting like a shield.
Oh, wow.
Yeah, by blocking the receptor, it stops the DHT from delivering its command. It shuts down the excessive oil production right at the hormonal source.
And it achieves this locally without requiring the patient to swallow a systemic hormone pill that affects their entire body.
Exactly.
It's like changing the locks on the doors of the oil factory so the hormonal boss can't get inside to give orders. That is incredible engineering.
It offers a phenomenal new pathway for patients suffering from hormonally driven acne who either cannot tolerate or just do not want to take oral hormone-altering medications.
So, synthesizing all of this complex chemistry, what are the ultimate takeaways for you, the listener? First, protect your skin barrier and your wallet. Do not buy the 10% benzoyl peroxide simply because it boasts a higher number. The 2.5% concentration does the exact same job without burning your face.
Absolutely. And second, respect the volatility of the chemistry lab. Keep your retinoid traffic cops far away from your benzoyl peroxide unless you want to oxidize and destroy the medication you just purchased.
Third, remember the orange warning. Never mix dapsone and benzoyl peroxide. And finally, recognize that the texture of the medicine is critical. If a thick cream feels suffocating on your skin, advocate for yourself and ask your doctor for a lightweight gel or a foam.
The ultimate goal of understanding this medical literature is to give you agency.
Yes.
When you grasp the cellular mechanisms, when you understand how a retinoid alters DNA transcription or how azelaic acid halts melanin production, you are no longer a victim of aggressive marketing. You're making precise, informed decisions about how to fundamentally alter the biological environment of your skin.
You are finally walking through that overwhelming pharmacy aisle with a scientific manual securely in your hands. But before we finish our deep dive today, there is one final, really provocative data point hidden in the literature that you need to consider.
Yes, and it involves that localized hormone blocker we just discussed, clascoterone.
Right.
While it's a brilliant innovation, the clinical trials highlight a very specific, rare adverse effect. Extensive use can cause hypothalamic pituitary adrenal axis suppression.
That is a very dense medical phrase, but the implications of it are staggering.
They are. The HPA axis is essentially the central communication network between three major endocrine glands: the hypothalamus and pituitary gland in your brain, and the adrenal glands above your kidneys.
Okay.
This axis regulates your body's stress response, your digestion, your immune system, and your mood.
And the clinical data is telling us that rubbing a seemingly simple cream onto your face to treat a few pimples can be absorbed deeply enough into your bloodstream to send a chemical signal that actively suppresses the master hormonal control center deep inside your brain.
It's a stark reminder that the human skin is not an impermeable shield or a plastic wrapper. It is a highly active, porous, living organ that is in constant direct communication with our most vital internal systems.
Which leaves you with a fascinating question to ponder the next time you're standing in front of your bathroom mirror. If a targeted cream designed for mild acne can cross the barrier and alter the hormonal axis inside your brain, what else are we casually rubbing onto our skin day in and day out, without ever realizing the silent, complex conversations those chemicals are having with our internal organs?